Hello, everyone, and welcome to the AFTD Educational Webinar, the role of neuropalliative care in FTD. I want to take a moment and apologize because GoToWebinar is not allowing us to show our cameras today. But I hope you will join us and be able to watch this webinar and listen via the PowerPoint and our voices. I'm Esther Kane, AFTD Support and Education Director. On behalf of everyone here, thank you for joining us today. A few housekeeping items before I introduce our guest presenter. Please note, our audience will be muted for the duration of the presentation. This helps to keep the background noise to a minimum so that everyone can hear the presenter clearly. If you have any technical issues, please write a message in the questions box and AFTD staff will try to address them with you. There will be time for Q&A at the end of the presentation. Please type your questions in this box as you think of them, and we will address as many as time permits. Additionally, this webinar will be recorded and archived on our YouTube page with all our other educational webinars. Visit youtube.com/theaftd.org to find our webinar playlist. Before we get started, I would like to point out a couple recent developments in the world of AFTD. Our website, theaftd.org, now has a brand new section devoted entirely to the FTD genetics. If you have any questions about the genetic causes of FTD, visiting a genetic counselor, or taking part in genetic testing, you will likely find answers here. World FTD Awareness Week begins on Sunday, September 26th. This yearly event is a great opportunity to spread FTD awareness and education in your local communities and beyond. This year, World FTD United is putting together a special presentation called the Global Conversation on FTD. People from around the world have submitted personal testimonials about how FTD has affected them and explain why they have reason for hope. AFTD is proud to be a part of the global conversation. Visit worldftdunited.net on October 2nd to take part. AFTD's annual Food for Thought campaign kicks off on September 26th. And this year, we are partnering with the FTD Hot Shot Challenge. Last year, AFTD volunteers organized this social media challenge, which involves taking a shot of hot sauce, posting the video to social media, and challenging your friends to take a shot as well, all to raise funds and FTD awareness. Visit AFTD's website to learn more, and be sure to follow the hashtag FTD Hot Shot Challenge on social media starting September 27th. At this point, I would like to introduce our guest presenter, Dr. Christina Vaughan. Dr. Vaughan is an associate professor of neurology and medicine at the University of Colorado and chief of the section of neuropalliative care. She completed medical school in her hometown at the State University of New York at Buffalo, followed by neurology residency at the University of Pittsburgh. Having grown up with two immediate family members living with neurodegenerative disease, she chose to pursue fellowship training in movement disorders, which she completed at Rush University in Chicago. She joined the faculty of the University of Colorado in 2017. Welcome, Dr. Vaughan. We are very glad you are here, and now I turn things over to you.
Thank you so much, Esther, and thanks to the AFTD for inviting me. I'm just making sure my slides are viewable. Hopefully you can see them. And we'll go ahead and get started. So I'm here in Denver, Colorado, and I'll speak for the next probably 35-40 minutes on the role of neuropalliative care in frontotemporal dementia. I'm going to advance my slides. I have no disclosures or conflicts of interest. And I like to start with this quote, which says, "Hope does not lie in a way out, but in a way through," by Robert Frost. So I have really just two goals as I set out to give this talk today. One is to define palliative care. We've got to start there because there's a lot of misconceptions or even just a lack of knowledge. Plenty of people have never heard of palliative care. So I'd like to define what it is and what it isn't. And then secondly, review how palliative care can help people live well with FTD. So let's get these misconceptions out of the way. First of all, a lot of people ask me, is palliative care hospice, or even just assume palliative care is hospice, and that is not the case, and I will explain that more in detail shortly. Secondly, some people say, oh, palliative care means giving up, and there's a pivot to focusing on trying to live well and seek treatment, and now we're just giving up. That is absolutely not true. Some people mistakenly think that palliative care means doing nothing. That couldn't be farther from the truth. Others think that palliative care is only for people at the end of life, and once again, not true. In fact, hospice is for people who are at the end of life, but not palliative care. Some people think palliative care is only for those who have cancer diagnoses, and the whole point of this talk is to show the role of palliative care in neurology patients, people with brain-related conditions like FTD, so certainly not exclusive for those with cancer. And then some people say, and in fact, I hear this pretty often, even from my colleagues in the hospital, saying, oh, it's not time for palliative care. And this drives me crazy because, in my opinion, it's always time for palliative care in the face of a chronic illness of any kind. And another misconception is sometimes people use this phrase, oh, he or she is on palliative, as if it's a status of some kind, like we've switched the goals and now we're just on palliative. And I just want to emphasize and get all of these misconceptions out of the way. These are not accurate in any way. So let's move forward. What is palliative care? Some people hate the word palliative or don't like it because they feel like it has a negative connotation or a negative charge to it. And I'm a purist. I guess I'm old-fashioned. I love the word palliative because it comes from the word palliare, which means to cloak. And I love the visual because to me, it reminds me of another layer of support. And that is absolutely what we're intending to do by offering palliative care or coming alongside other medical teams and providing palliative care. So please remember this visual because I think it really helps emphasize what we're seeking to do. So let's get into what it really is. First of all, it's a medical specialty. For those that train formally in palliative medicine, physicians that pursue this complete a fellowship, which is a one-year extra training program, and there's a board exam. In addition to being a medical specialty, it's an approach to care of those affected by serious illness. And by that, I mean we're focusing on quality of life and trying to identify all the different kinds of challenges and sources of suffering. Because think about it, when we're living with any sort of condition, a serious illness of any kind, there are a multitude of ways that it affects the person with the diagnosis and everyone around them. So we'll focus on symptoms, whether it's treating physical symptoms, psychiatric or psychological symptoms. We also focus in palliative care on the psychosocial issues, the practical side of living with the condition. We focus on spiritual well-being and the big picture, planning for the future. I would say these four elements are really the key pillars to what we're seeking to do with the palliative care approach. So think about, as I said, all of the different ways a medical condition can affect certainly the person with the diagnosis, but those around them, the family. There's the physical manifestations, whether it means having coordination problems or balance problems. There's the psychological piece, whether it's reacting to having a diagnosis now, whether it's depression or just depression being a feature of the disease itself, a symptom. There's the social aspect, perhaps feeling more isolated out in the world now that this diagnosis has been made. The spiritual piece, sometimes people are trying to cope with a diagnosis by thinking, why me? What did I do to deserve this? And that adds a whole extra layer of suffering. The practical side of living with a condition, whether it's dealing with transportation, if someone's no longer driving but still needs to get to appointments, whether it's housing situation, and end-of-life worries. People thinking, wow, now I have this diagnosis. What does it mean? Does this mean my life's over? Does it mean the end is coming quickly? So you can see there's a whole variety of different ways that a diagnosis like FTD or like a chronic neurologic condition can affect a patient and family in many different domains, simply not just the physical domain. And we think in palliative care that this is best addressed by a team. No one person, no one physician or nurse practitioner can handle all of these domains. We simply just don't have that expertise, right? I don't claim to be a spiritual care counselor, adept at talking through existential struggles as much as I'd like to. And so we bring in a team. Palliative care is best provided in a team. So at the center of the team is the patient and the family, or whoever's close to them, chosen family or otherwise. Then there's a medical provider, a physician or a nurse practitioner or a physician assistant. And that person is certainly focusing on symptoms, medications, things like this. Then we also have a social worker, and that person, social workers, you probably realize, wear so many different hats and have a lot of skills, whether it's tapping into support groups, providing resources for transportation, housing, etc. Social workers are extremely critical in the palliative care approach. Often we have a nurse who's providing a variety of different forms of care, doing safety assessments, potentially talking about advanced care planning, and then a chaplain or a spiritual counselor. A lot of people don't realize there is a type of chaplaincy where chaplains get training, special training in medical, on the medical side of things. And a lot of hospitals have hospital chaplains, and on palliative care teams, we try to always have a chaplain when we can, a spiritual counselor to help people discuss coping. They can work with the patient, the family, both. And so this is a snapshot of what a palliative care team might look like. Again, with the patient and family at the center, trying to identify a variety of different sources of challenge and suffering, and applying each person's expertise to trying to manage or help with those different domains. So another way, for those that don't like the word palliative, despite my plea to use the word, supportive care is another way of describing what this is. Some institutions don't use the word palliative and call this kind of team or this kind of approach supportive care team. And really the idea is to come alongside your current medical, or in this case, neurologic team, to work with or in collaboration with your neurologist to provide, again, that cloak idea, an extra layer of support to both the patient and whoever's close to them, oftentimes the family. That is, if we distill it down, what we're talking about. It is definitely not high tech. We like to say it's high touch, if you will. So this supportive care idea, to distill it down further, this idea of what palliative care is seeking to do is simply to help people do as well as possible for as long as possible in the face of a serious or chronic illness like FTD. That's it. That hopefully demystifies a bit what palliative care is and seeks to do. So how does this differ from typical, in this case, neurologic care, typical care with a neurologist? Well, historically, neurologists, once a diagnosis has been made, seek to try and preserve function as a primary goal, whether it's helping people with independence, helping people walk, helping people complete activities of daily living, really putting blinders on and focusing on function. But when you bring in the palliative care team or the palliative care approach, we're trying to add this idea that in addition to preserving function, we're trying to relieve suffering. And again, very conscious of the fact that there can be multiple types or reasons for suffering when living with a condition. Whereas usual care often has this perspective of just trying to prolong life at all cost. With palliative care, we're trying to prolong quality of life. I really want to emphasize that distinction. And that means looking at the long haul, the long road, thinking ahead about the future, planning for the what ifs, thinking about what happens as things progress, as things decline. How can we be prepared for that? and have a plan in place, and therefore come up with an advanced care plan. So palliative care isn't just talking about prolonging life. Sure, that's part of the conversation, but it's really prolonging quality of life. Whereas usual care usually focuses on the patient pretty exclusively, the idea with palliative is to focus on the patient and whoever's close to them, you know, the family, because we know these conditions like FTD affect everyone who's close to the person with the diagnosis. Usual care usually focuses on the medical and perhaps the psychiatric symptoms of a brain condition. But in palliative care, again, we're trying to also introduce the psychosocial and spiritual issues that may arise in a situation like FTD. Sometimes you might find a team-based approach in your regular neurologic care. They may bring in physical therapy, speech, occupational therapy, those kind of team members. But palliative care consistently is trying to have a team-based approach. Whether or not the team is physically present in a visit can be variable, but having access to a team is really the goal when palliative care is involved. So these are some differences between what's different about palliative care versus just plain neurologic care. So let's get rid of this myth or this idea that palliative care and hospice are the same thing, because honestly, this is a common misconception, as I said a few slides ago. So let's talk about how they're the same and how they're different. Both palliative care and hospice seek to focus on the whole person, taking into account all aspects of living with their condition. But the key difference is that palliative care is an option for anyone at any stage of their condition, of their serious illness, whereas hospice is intended for people that are thought to have a 6-month or less life expectancy or prognosis. And so this is really the biggest point. You can see hospice is reserved for people at the end of life or who are thought to be at that stage of their condition, whereas palliative care is anywhere upstream from that. In fact, as soon as the time of diagnosis would be a great time to have palliative care get involved. Another difference between palliative care and hospice is that people enrolled or receiving palliative care can continue to receive disease-modifying treatment. I think this makes more sense in the setting of something like cancer. Perhaps somebody is receiving chemotherapy, palliative care gets involved, nothing changes. They continue receiving chemotherapy if that's the plan. But if somebody's enrolled in hospice with, in this case, a cancer diagnosis, they no longer are eligible to receive disease-modifying treatments, things like chemo or otherwise. And so the focus for people who are enrolled in hospice is strictly on comfort above all else. And that's not the case in palliative care. People receiving palliative care can get all sorts of other treatments. It doesn't limit them in the other kinds of medical treatments they can receive. Where can palliative care be provided? Well, a variety of places. At a hospital, if somebody's admitted to the hospital, there are often palliative care teams that live essentially in the hospital and provide care there. As in my case, we provide clinic-based neuropalliative care. And there are freestanding palliative care groups and communities that can come to the home and provide community-based palliative care. So palliative can be received in a variety of different locations. Hospice care goes to where the patient is. So if the patient's living at home, hospice comes to them there. If the patient's living in a facility, hospice goes there. Hospice is rarely a freestanding facility. I think decades ago, it was more common to have hospices as buildings or places where you would go, but that is very rare at this point in time for a variety of reasons. So hospice is typically a team that comes to wherever the patient is. So these are some key differences in what palliative care is versus hospice, and I hope you can appreciate that they are not interchangeable at all. The similarities, though, is that the approach, again, is to focus on the whole person, paying attention to all the different aspects of quality of life, not just physical, emotional, spiritual, psychosocial. So they do have that in common, that elemental focus, but beyond that, there are some clear differences. So how does this look? As I said, palliative care can be provided community-based, where a team can come to the home. They typically don't come often. They come, at least in my experience, every 4 to 6 weeks. Usually a nurse practitioner will come to the house, check vital signs, review symptoms, medications, and check in and see if additional help in the form of a social worker might be helpful. And it's not a lot of frequent visits, but they are there as another layer of support, another set of eyes in the home. Hospital-based palliative care I mentioned, and then clinic-based palliative care is what I practice most frequently, and that's where a patient and family comes to the clinic as they would for a normal neurology visit. And instead of a normal neurology visit, they're having a neuropalliative care visit. And just briefly, this is what our clinic group looks like here at the University of Colorado. And this setup, this structure has been in place for about 5 years now. And so on the medical side of things, currently, we have me as the neuropalliative physician. I have a colleague who's another physician trained in neuropalliative care. My right hand is next to me there, my physician assistant. She has a master's in palliative care. And then we have a nurse. We have a social worker within our team, and we have the social worker who's part of the neurology group, the whole department. We have a lovely chaplain, and then we have a couple of administrative staff who are really key to making things run. And we're very fortunate to have a couple of volunteers, one who's a patient and one who is the spouse of a prior patient, both who have been extremely helpful in supporting what we do and reaching out to patients and care partners. So that's a snapshot of what our clinic team looks like. And when we see patients in clinic, not everyone's available necessarily all the time. In fact, sometimes we connect patients and families to our team members by phone or by telehealth. It really just depends on the logistics. So we certainly don't go all together into the room at the same time in the clinic. We go one at a time and spend time individually with the patient and family. So how does this relate to FTD? Is it useful? Is it relevant? Let's make sense of this and see how this can apply here. So one of the main tools, I'd say, that we use in palliative care in the approach to taking care of patients is to try and establish what an individual's goals of care is. And I'd say this is almost like a procedure. It's an exploration of trying to get to know the patient and family and trying to understand what's most important to that person, in this case with FTD and his or her family, and then align what's most important to them to what's possible medically moving forward. And so goals of care and spending the time to try and understand who the person is, what's important to them, what they're hoping for and worried about, this really serves well to think about next steps and further care. And I really like this quote by Atul Gawande, which says, "Our most cruel failure in how we treat the sick and the aged is the failure to recognize that they have priorities beyond merely being safe and living longer." And I like this quote because it's a reminder that in medicine, until we ask the questions, what's most important to you or what's bothering you the most, we really don't know. We can make all sorts of assumptions and say, well, clearly their priorities must be living longer, but in fact, maybe it's something else, or maybe it's something just slightly different. We don't know until we ask, and that's where this idea of goals of care comes in. So what does that look like? It's an exploration. So when I first meet a patient and family, the very first visit, I say, let's put the medical side on hold just for a few minutes. I've already read your medical record. It's a very medical record, right? There's not a whole lot in the chart about who you are as a person, what life was like before the FTD diagnosis. So I'd really like to hear about that. And if the person with FTD is struggling to be able to communicate or having some difficulty, we rely on the family or whoever's with them to fill in the gaps and to tell us the narrative of what life was like before. So we'll ask questions like simply, what was life like before FTD? You know, and if people, it can be a little hard for people to pivot and say, what do you mean we're going to talk about non-medical things? And they might be stumped and say, well, I don't know what you want me to say. So I'll start by saying, you know, have you always lived in Colorado? Because that's where we are. And that takes people back to another point far in the past, usually, where they say, oh, well, yeah, I was born here. And then that gets us going in a dialogue so that we can get a bit of narrative and history about their life. Asking people what they're most proud of can be also very helpful because it gives us a clue as to how this person sees themselves, perhaps. A lot of times people might say, well, I'm a mom. I'm really proud of my kids. And that really helps us understand their identity. And then also see, gosh, now that they have FTD, how is this interfering with how they see themselves? Another question, how do you define quality of life? It certainly means different things to different people, and it's really worthwhile to ask this question. Asking people what they enjoy. What brings you the most joy? What are you looking forward to? What makes you happy? What fills your cup? What fills your soul? However you want to ask these kinds of questions. This is also important because part of our goal is to figure out how we can get them more of that activity, that experience that makes them happy, that makes them feel better. It's not all about medication. So asking this question is also very important. How do you make sense of your FTD? Sounds like a weird question, doesn't it? If some physician is saying, how do you make sense of this diagnosis? Well, it gives us a lot of information to ask this question. First of all, it lets us in to understand what the patient's understanding is of their condition and to see where they're at with making sense of it and saying, well, this is a brain-related condition. This is the reason that I am having difficulty communicating or something like this. Really trying to understand where they're at with making sense of their diagnosis is important. It helps us further communicate better with them. And then also sometimes people are experiencing additional suffering because they think they did something wrong. Sometimes patients will say, I've got this diagnosis and I know it's because I did this thing in the past. I, had exposure to this pesticide, or I drank too much, or God is punishing me. I mean, there's a whole variety of reasons why people sometimes think they've been diagnosed with a condition like FTD. And if we uncover that, we can get a clue into additional suffering they may be having because of how they're thinking about it. What's the hardest part of this is another question I like to ask during my goals of care discussion, because once again, until we ask, we really don't know. We might make assumptions that, oh, maybe it's forgetfulness that's the hardest part, but in fact, it's something else. I remember the spouse of a patient with FTD saying, what the hardest part for me is? I can't take my husband out anymore because he has this tendency to stare at people in a really mean way that isn't intentional. It's just part of his condition. And people start to get offended and actually come over to him and want to start a fight because he stares at them in such an intense way. And now she can't take him out. And so that was the hardest part for her. And that's just not something I ever would have thought about. And knowing that helps us think, okay, well, how can we work around that or work with that? So that's a very important question. What are you most worried about and what are you hoping for? These are two different sides of the same coin. Asking people about hopes and worries allows us insight into thinking about the future with them. What are you hoping for? Some people say, I'm hoping to always live in my house. I never want to go to a facility. Or I'm hoping to go to my college reunion next year. I'm hoping to see my children graduate college. Whatever it is, knowing what their hopes are helps us keep that in mind as we plan next steps medically. So in summary, this is a list, just some ideas of questions that we might ask in a goals of care discussion within a palliative care visit to try and better understand the person behind the diagnosis. Who are they really? What are they hoping for? What's the family hoping for? And so on, so that we can use this information moving forward. And by that, I mean, what we're trying to do is then generate a plan of care. So now we've had our goals of care discussion where we've tried to extract values, hopes, wishes, personhood, meaning how someone sees themselves, their life story to some extent, really collecting all of that information and then saying, now what? What do we do with that? Well, we help people navigate next steps in medical care, whether it's needing a new medication, whether it's considering a clinical trial, the pros, cons, risks, benefits, burdens, whether they need more help at home or transition to a different kind of care or housing situation, whether they're considering surgeries. Sometimes people who have advanced dementia may be presented by their primary care doctor with the option for a colonoscopy. Say, oh, it's time for your routine colonoscopy. Well, do we really need it? Maybe, but maybe not. It's worth a conversation in checking in with the patient and family about their goals, what they're hoping for, what they're willing to do and not do, and help them make that decision, whether or not they want to proceed with a procedure or a surgery, for example. And then thinking about code status, which simply means whether or not a person would want attempts made at resuscitation if their heart or lungs stopped. You know, those things aren't expected in FTD, but this applies to anyone in the world. You know, would we want to have aggressive measures done if we suddenly got really sick unexpectedly? So all of those medical type decisions on the right side of the slide are things that we can help navigate once we have a better sense of what's most important to a patient and family in the setting of their condition. And that's how we generate a plan of care. It's a negotiation between the goals of care and what's medically possible. And that's really why I think the goals of care can be supremely useful in having that conversation with people. So another reason why palliative care can be useful in FTD are the variety of psychosocial stressors that both patients and families undergo. Naturally, there's changing roles and relationships as the FTD progresses. People often have loss of autonomy and need more help with things. There's ongoing threats to personhood. As I said, once somebody has seen themselves as a mother, say, for many, many years, and now with a condition like FTD, doing the things they used to do in that role could be much harder, and therefore they have a shift in how they're seeing themselves, and that can be really hard to navigate. Financial strains can be a reality in a condition, particularly like FTD, especially if it starts earlier in life, where somebody was expecting to work for many, many more years and now is not. Communication difficulties certainly can be a challenge, both for the person with the diagnosis and anyone around them trying to communicate. Social isolation is not uncommon, where people are less inclined to want to interact with those in their community and so forth. There can be cosmetic effects. You know, sometimes people with various forms of dementia may develop trouble handling saliva, and you know, there may be some drooling. It doesn't always happen, but for example, that can be a really big problem for some people where they just don't want to be seen with something like that. And social stigma. Sometimes people feel really embarrassed or ashamed, unfortunately, that they have a brain-related diagnosis. And all of these are unique psychosocial stressors, I'd say, to various dementias, especially FTD, and provide or contribute to the challenge of living with it. And so how can we help? Well, in this case, a social worker, who I said earlier, has many hats that they wear and many things they're able to do, could make a referral or connect a patient and family to an attorney if they want to talk about disability or will planning and that sort of thing. So, social worker could provide or connect a family to counseling services to try and really dig into coping through this. Social worker could connect a family to support groups, both locally, regionally, or nationally. And find FTD-specific programming in the community. So that's just a smattering of things that a social worker would be particularly helpful for in addressing some of the psychosocial stressors. As I said earlier, issues around transportation, oftentimes a social worker can help provide ideas, suggestions about safer forms of transportation, for example. And these are all skills, right, that as a physician, I certainly don't have, which is why it's really essential when we're trying to support families and patients to have a team with people who have different forms of expertise. In FTD, there could also be unique sources of spiritual distress, right? Grief. I think grief is something that's often overlooked in progressive neurologic disease, because a lot of times people feel and families feel like they're losing one thing at a time. These diseases are often likened to thieves, you know, robbing people of different abilities or capabilities over time. And there's absolutely grief associated with these losses. And naming it and trying to make sense of it and process it can be very therapeutic and helpful. And again, that would be best done by someone other than a physician usually. In this case, perhaps a chaplain. So dealing with the grief, the guilt, sometimes care partners, family members feel guilty for a variety of reasons, for feeling like they need to focus on self-care, which is absolutely necessary for care partners living with someone with a chronic disease. They might feel guilty that they're the healthy one. There's just a lot of potential reasons that guilt might be part of the equation. And again, it's important to identify it and then figure out how we can work through it. Fear of cognitive decline, existential crises, death anxiety. There's a whole host of sources, potential sources of spiritual distress that people may experience, both patients and care partners, when living with FTD, that a chaplain may be particularly skillful in addressing. Chaplains can provide counseling, mindfulness. A lot of people get scared and say, I'm not religious, I don't want to meet with a chaplain. Well, the chaplain, in my experience, never brings up religion initially unless the patient goes there first or the family. Certainly they're very well versed in speaking about spiritual and religious topics, but they can simply be present for counseling, talking about grief, talking about family dynamics, providing guided imagery or suggesting creative practices, and potentially connecting people with faith groups if that would be helpful. There's a whole host of potential ways that chaplains or spiritual counselors can be helpful to patients and families living with something like FTD. I also like this quote by Viktor Frankl, which says, "We cannot avoid suffering, but we can choose how to cope with it, find meaning in it, and move forward with renewed purpose." And I think the topic of meaning is also a very important topic. Our chaplain actually just gave us a lovely talk on meaning in the face of serious illness just the other day this week. And cultivating ways of finding new forms of meaning or revisiting old forms of meaning, but nonetheless recognizing all the different ways we still have meaning, no matter where we are in a disease course or where we are in our life. So chaplains are particularly skillful at that as well. The other piece of this, of the many pieces of areas where palliative care may be helpful in FTD management, would be focusing on the care partner, on the caregiver. Caregivers inevitably have various forms of distress and struggle in the face of a serious illness or a chronic illness, a neurologic disease, and they may be underprepared for the role. I mean, nobody's really expecting to get these kinds of diagnoses. No, certainly no one signs up for it. The person with the diagnosis, the patient, and the care partner. Nobody signed up to go through this, but here we are, you know, living with this diagnosis, and there's no how-to book, right? You tap into resources like support groups and the AFTD, but it's challenging to know, am I doing this right? You know, what should I be doing differently? So that's a form of distress just by itself, questioning whether they're doing everything right or taking good care of their loved one. The roles are evolving in the family unit. You know, as conditions progress like FTD, naturally the roles are going to shift in a family or in a relationship. There may be high levels of burden, and just in general, someone who's in the role of caregiver or care partner in any sort of condition is at risk for having depression and potentially increased mortality if the stress level is sustained and very high for too long. And so distress or burden associated with being in the caregiving role, again, with pretty much any chronic disease, not just FTD or a form of dementia, can interfere with spiritual well-being, interfere with health-related quality of life, can result in caregiver anxiety, depression, and really be a challenge for the person who is standing there as the caregiver. And this is something we talk about a lot, or try to, in our visits in palliative care, to actually check in with the care partner and say, how's your quality of life? How are you doing? Do you have time to go to your own appointments, your own medical visits, get your hair done, whatever it is? Who do you talk to? Who do you lean on? And really highlight that, shine a light on what they're doing, what they could be doing more for themselves, and also give them permission to do it. Sometimes people get so caught up in the role of caregiving that they don't step back. There's no time, right? To just step back and be like, wow, I'm not doing anything for myself. I'm not even getting my routine doctor visits myself. So anyway, having these conversations is an integral part of the palliative care approach. And what about future planning? I think this is another area where palliative care is extremely important for all conditions, and certainly FTD is no exception. So advanced care planning, or creating an advanced directive, is planning in advance for what you would want or not want if you couldn't speak for yourself. And this is important for every single person, FTD or not, care partners, family members, and so forth, to think through what would be acceptable or not to you if you suddenly got unexpectedly so sick and couldn't speak for yourself. When people are at the end of life for whatever reason, at least 70% don't have capacity to make their needs known and say, well, you know what, I would want this or I wouldn't want this. When people are so sick at the end of life, if that's where they're at, they're not able usually to articulate what is most important to them or not. And if it's documented in advance during a time when there is no crisis, you know, upstream from any expected problem, people are more likely to have their wishes followed when they are eventually at the end of life. And this is known to actually result in less stress, anxiety, and depression, and higher satisfaction in the family members who are ultimately left behind for whoever it is that passed away. So the bottom line is, planning in advance for your medical care for all of us is extremely important, helpful to the family, so that if the family finds themselves having to make decisions for someone, they don't feel the burden of not knowing where to start, because now they've got a document from their loved ones saying what would or wouldn't be acceptable. And I'll say, during the pandemic, for the last year and a half, it's really allowed us almost an easier time having these conversations, because people started to think, gosh, if I suddenly got so sick with COVID that I wasn't able to breathe on my own, would I want to be on a breathing machine? So that has really lended itself to putting in perspective why these conversations can be really important for all of us. And so palliative care teams are pretty skillful and experienced in having these conversations. And people say, oh, I'm not ready to have this conversation, and you know, oh, it's not time yet. It's always time to just figure out what would be acceptable or not to you. We prepare for all sorts of emergencies in life, right? Whether it's preparing for a snowstorm here in Colorado, getting fire insurance, stocking up on toilet paper in a pandemic, whatever it is, we prepare for all sorts of emergencies in life. Why wouldn't we simply document, if an emergency happened, what we would or wouldn't want done, and who we would want to speak for us on our behalf? So planning for the future and not belaboring the point, just having the conversation and helping someone document it is part of what palliative care is particularly good at. And again, it's associated with good things. I think when people have the conversation with us documented, there's usually a sense of relief, like, we just had a hard conversation. We came up with some plans on the what ifs. What if this happens? What we'll do? Now we don't have to talk about it again necessarily, and there's a sense of relief that goes along with that. So it can be really gratifying actually to have these hard conversations. And you know, it also allows people to be protected from things they wouldn't want. Some people are like at a stage in their life where they're like, you know what, I would never want to undergo shock treatments if my heart was beating in a certain way. I would just not want that. Great, now we've written it down, and we'll protect that person from having that happen if ever they wound up in that situation. Interestingly though, less than 10% of neurologists, you know, brain-related specialists taking care of patients that have brain-related conditions like FTD and other dementias, it's rare that we as neurologists initiate these kinds of discussions about advanced care planning at the time of diagnosis. I think, you know, these conditions kind of progress along over time, and we think, oh, you know, we'll have time to have these discussions later. And there's really no reason to postpone these kinds of discussions, because certainly in the case of FTD, somebody over time often loses their ability to make their needs known or express their wishes in a meaningful way. So to have these conversations as early as possible makes the most sense. So if we look at FTD over time and consider this slide like a timeline going left to right, and it's many years, unclear how many years, but this is over the course of years, I would like to make the case that palliative care makes sense to come on board in the care at the time of diagnosis. In the top left, you see a DX, that's the abbreviation for diagnosis. In the timeline, at the time of diagnosis would be a great time for palliative care team to help identify a decision maker. In other words, who would be your voice if you couldn't speak for yourself about medical decision making? Let's just document it. Here in Colorado, this is a state where if it's not documented, there's no hierarchy. In other words, if someone winds up in the emergency room, unable to speak for themselves, and there's no documentation, they're by themselves, the physicians, the medical team doesn't default to the next of kin or the spouse. Instead, we have to round up all interested parties and get a consensus from that group of people on who would be the spokesperson. It's an epic waste of time, and it can simply be avoided by documenting who would be your medical power of attorney. So we can be helpful with that at the time of diagnosis early on in the course. We can also, moving forward in time, provide the extra levels or layers of support, whether it's spiritual support, care coordination, help from a social worker, dealing with psychosocial needs. If there are complex symptoms that have evolved, perhaps the person also has pain, not that pain is necessarily expected in FTD, but maybe they have other medical issues that are causing physical pain. We might be helpful in that regard. And then moving forward at time point number 3, however many years that is later, talking about prognosis. Sometimes families and patients want to know, how much time do you think I have with this condition? What do you think lies ahead? And while we're not necessarily that good at these predictions, we still don't want to cop out and say, well, I don't know, I don't have a crystal ball. That's not the right approach. Instead, as palliative care teams and physicians, we want to try and talk through the possible what ifs of the future, if in fact the family and patient want to talk about that, because it can be helpful for planning. So having those kinds of conversations, palliative care can be particularly helpful with as well. Preparing family for the what ifs, managing additional complex symptoms. Sometimes constipation can get really out of control in various brain-related conditions. We can help with that. Talking about legacy work with patients and families, thinking about, are there things you want to do to kind of shore up your legacy for once you do pass away, whenever that is, things that you could do now that would be meaningful and impactful and help you with legacy making. At time point number 4, palliative care team could come alongside and, for example, facilitate family meetings. Last week or a couple weeks ago, I met with a husband of one of my patients who has dementia and her 3 or 4 sons virtually over telehealth. They're in different parts of the country. And we talked through in this family meeting where things were at with her, and also next steps on getting more care at home and some of the worries that the family was having that they hadn't yet shared with the spouse, with their dad. And facilitating those family meetings is something else we can help with in a palliative care setting. As somebody does approach end of life or is much sicker or more debilitated, we can introduce hospice, and it would just be a discussion on what I said earlier on what hospice is and what it isn't, and how it can be helpful for people and families in providing extra support. In this country, hospice gets involved much too late. The average time someone spends enrolled in hospice is on the order of something like 2 weeks. And they've missed out on months of extra support and help, equipment, etc. And that's largely because we refer people later than we ought to hospice. Perhaps we're on the medical side afraid to have the conversations, or we wait until a crisis happens and then in a flurry bring hospice. And it doesn't have to be like that. We can talk about it sooner and just orient people to what it is and what it looks like and just demystify it. Then at time point number 5, we can continue an ongoing management of symptoms, and we can talk through care transitions if somebody needs a higher level of care, for example, going from assisted living to skilled nursing or getting more help at home, whatever that looks like, talking through that, bringing in the social worker, that can be helpful. And when somebody is at the point where we think we wouldn't be surprised if they were to pass away in the next 6 months, then we do recommend hospice and help connect families and patients with hospice. And that's where people receive teaching, medications, nursing support, home aides, volunteers, et cetera, 24 access to the hospice team. They're not there around the clock, certainly, but they're available by phone. And then once somebody does pass away, hospice provides 13 months of bereavement support, grief support to the family. 13 months, and that's a benefit a lot of people don't realize that hospice offers, whether it's counseling or support groups. I think it's important to know that. So this is a timeline potentially of something like FTD, where different times along the way, it would be helpful, particularly helpful, to have a touch point with the palliative care team. So as I wrap up, I would ask the question, what does it mean to live well? Again, questions are so powerful. As I listed several of them earlier, they can really give us insight into people's perceptions of their lives, what's most important to them, what constitutes quality of life. And so living well with FTD absolutely means different things to different people. And it justifies ongoing conversations with the care team on what that would look like, and seeing how the care team can help manage that and help bring quality back if it started to fall away. I would say one way to describe what it means to live well is having the energy to engage with life in a meaningful and fulfilling way. And I think the care that I'm describing, or the approach to care that I'm describing, seeks to support patients and families in multiple different ways, paying attention to as many sources of suffering as we can and trying to alleviate that with the expertise of different team members. So in summary, how can I live well with FTD? Or how can we live well together with FTD? I would say my advice would be to identify a care team to strategize with you regarding how to bring more meaning back into your life, whatever that looks like. And as I said before, a lot of times a chaplain can help with that. Sometimes it's a long-standing primary care doctor, someone you have a long-term relationship with already on your medical team. Considering extra support at home, it's always worthwhile just to talk about what that might look like. A lot of people feel reluctant for a variety of reasons, privacy, et cetera, COVID, et cetera. But just demystifying what that would look like. What would it look like to have a little bit of help at home? There are some organizations that provide help at home that insist on a 4-hour minimum per week, but there are others that might have less. We just have to look for those. So talking through that with a social worker can be helpful. Familiarizing with community resources. Since you're all on this call anyway, you're already familiar with AFTD, so you're well aware of resources on a national level. But sometimes you don't know what you don't know, and checking in with social workers and other groups might be helpful to value or let you know about other possible resources. Respite care is another resource people often don't pay attention to or know about, and that's simply in the face of an illness. If a care partner or family member needs to go away on a trip or just needs to get away for a few days, respite care means that their loved one with the diagnosis is temporarily cared for, usually in a facility for a few days. Social workers can help arrange that or talk through what that looks like. And then thinking about holistic symptom management, making sure that if you step back, you feel that the various domains of the way this illness is affecting you are being addressed in some way, not just the obvious things like memory trouble or other things that are obvious. Making sure there's a real holistic approach to symptom management can be helpful. And then establishing a long-term relationship. There's so much to be gained when you have a long-standing relationship with your medical team. They know you, they know what you've been through, they walk the road with you, and that can be invaluable. And then lastly, establishing a plan for the future, that advanced care planning that I mentioned. Although it might sound like a scary discussion, it doesn't have to be. As I said before, we plan for so many other emergencies in life. We have various forms of insurance, et cetera. This is one more thing to plan for. And it's a kindness to your family if you've documented what you would or wouldn't want medically if you got really sick. So my summary slide is here saying that palliative, or if you will, supportive care, aims to improve the quality of life of both patients and their families by addressing psychological and spiritual aspects of their condition, complex symptom management, assisting in the big picture and future planning, and providing extra layer of support. Remember, palliative comes from a word that means to cloak. And ultimately, the goal is to do as well as possible for as long as possible in the face of a serious illness. Thank you so much for your attention. I'm happy to take any questions. And if Esther wants to take back control of the slides, that's great.
Dr. Vaughn, thank you so much for this informative session. I feel like I have learned even more about the palliative care and the hospice process. So thank you for taking the time today to really go through this whole presentation. We do have some questions that I'd like to ask. You know, one of the big ones is, do you find that you get pushback from other neurologists when it comes to maybe referring to palliative care?
Yeah, I think that's a great question. I think, you know, things are evolving so that there's less pushback in my experience than there was several years ago. But before I chose to pivot and get extra training in palliative care, when I was practicing just neurology without the palliative care element, I thought that I was providing palliative care. You know, I thought, well, in neurology, what are we doing? We are focusing on quality of life. I think everyone in medicine wants to promote quality of life, including neurologists. Once we make a diagnosis, we aren't necessarily curing things, we're managing them and trying to optimize quality of life. So I thought, yeah, I'm doing palliative care. Why would I need an additional palliative care, you know, team or provider? And I think a lot of people don't realize, other neurologists, for example, that sure, while they are doing palliative care and often very skilled at it, there's a lot to be gained from the additional expertise of the other team members, right? The social worker and the chaplain and just the whole approach. It's meant to be interdisciplinary, meaning that the different team members are trying to really integrate their plans as opposed to just coming up with a separate plan and saying, well, the social worker says this, you know, in isolation without really understanding the big picture. So really trying to integrate all the different expertise of the different team members is a reason that palliative care is a great idea. And I try to explain that to neurologists. I think sometimes plenty of doctors, not just neurologists or medical providers, mistakenly assume that we're in there. Palliative, here comes the palliative care team. They're just going to shut it down and they're going to say, that's it, we're giving up. We're just going to focus on comfort. And once again, that's not what we're doing. We're not hospice, and we're trying to optimize things and just not interfere, but just fill in any gaps in care or identify additional sources of suffering. So in summary, I'd say, yeah, there's some pushback. Thankfully here in our department, in our university, there's so much awareness already about palliative care that I don't witness it really here as much as I might in a different place. It really depends on the culture of where you're practicing.
So speaking of that, how can patients get referred to palliative care clinics? You know, we get a lot of people who call into our helpline and who talk to us, and we hear the question of, we recommend they look into palliative care, and they had never heard of it as an option, or they've only ever heard of hospice. Mm-hmm. So how can somebody get started on this process?
It's a good question. Unfortunately, it depends a bit on where you live in the country, you know, what city or university you're affiliated with. So as I said, there's a lot of community-based palliative care programs, and they are in fact affiliated with hospice, but they're sort of like separate practices within an organization that's both hospice and palliative care. So the first step would be seeing if in your community there is a palliative care organization or several of them, and seeing, will they take on neurology patients? Some of them are still anchored in cancer and a few other diagnoses like heart failure or liver failure, that sort of thing. But more and more of these programs are taking on neurology patients, thankfully. So checking into the community to see if there are palliative care community-based programs. As far as clinics go, there are palliative care clinics in different hospital systems. Again, some of them are exclusively still for cancer, unfortunately, but more and more are developing. Thankfully, there's a huge increase in interest in combining neuro and palliative. So depending where you are in the country, there are more and more neuro palliative care clinics coming up. In fact, finally this year, actually next month, will be the first meeting of the International Neuro Palliative Care Society, the INPCS. And if you look that up online, you'll find out more information. And I think that would be a great resource for patients and families to advocate for getting palliative care in their care, because a lot of times if patients and families ask their provider, hey, I'd like to get palliative care involved, and the doc or the provider may not be familiar with what its role would be, or they might mistakenly think it's for end of life, then the family could say, hey, look at this website. The INPCS is a great resource to explain why palliative care is very relevant in neurologic disease, and as soon as possible at the time of diagnosis even. So I think being an advocate for yourself, having the information, presenting it to your doctor or your medical team if you in fact want to request palliative care is a good way to start. It really necessitates educating all the time, educating your doctors if they don't already know about it, educating palliative care teams that, hey, it doesn't have to just be cancer. So if you don't already have access to a palliative care clinic or one that allows for neurologic patients, then it really makes sense to educate people and see if they will take on patients with neurologic conditions if they weren't already. That's what I would say to that. And so unfortunately, it does depend on where you live, but I am extremely enthusiastic watching the growth of neuropalliative care in the country.
Yes, I agree. And I'm excited to see how we can partner with these organizations to help improve the care of those with FTD through neuropalliative care. One question we got is who pays for neuropalliative care?
In the case of our setup here, it's just like any other visit. Insurance covers it. You know, it depends on the organization which insurance they're covering and not covering, but it's just like a regular medical visit. So it's nothing above and beyond that.
And when I was practicing as a nurse, I saw more and more insurances covering palliative care. So have you seen a shift in maybe if somebody had tried 5 years ago versus now in terms of access to palliative care?
On the clinic side, I haven't seen any issues of it not being covered, since we're based in the neurology department and they already have a neurologic diagnosis. Then it's just another neurology visit that's neuropalliative care. So I haven't witnessed a shift in that way. Perhaps on the community-based palliative care side, maybe there is a difference in how insurances are covering it, but certainly within the clinic, thankfully, I haven't seen that.
That's wonderful. And for our participants in Colorado, I hope that you will seek out the clinic that Dr. Vaughn is talking about, because I think this sounds like a great resource for you. I think one last question, if maybe you can answer, is when looking at neuropalliative care, what are some palliative measures that someone might take for neurological symptoms that we see very often in our patients with FTD? For example, you know, there's a lot of behaviors associated with FTD. Do you guys help approach that?
Yeah, in many cases we do. It's, you know, certainly not all about medications, but sometimes medication adjustments can be helpful. So we absolutely try to take that on in collaboration with the other neurologists, adjusting medications, eliminating medications that are no longer needed, that could be making behaviors worse, for example, or interfering with sleep. And then on the non-medication side, we try to counsel families on ways to cope with behaviors. Sometimes certainly that's easier said than done. You know, it can be extremely difficult to manage behaviors. You know, it's one thing to theoretically say, oh, it's not my loved one, it's their disease causing this. But when you're in the moment as the caregiver and the recipient of some awful behavior, it's really hard. So we have resources in the community that we try to partner with. We talk about adult day programs for people. For some people that's helpful, for others it's not. We talk about having different groups of caregivers or different family that comes on a different day so that the primary caregiver gets away on a regular scheduled basis and trying to help them have a routine, because those behaviors can be so hard to deal with and they need to step away. And for us to help them plan on how to do that. But yeah, partnering with counselors, we have some wonderful people in the community that are really skilled at doing home visits and sort of in a consultative role and making suggestions about how to manage certain behaviors. For people that might wander, we discuss different ways to help make the environment safer to prevent wandering. There's a variety of tips and tricks that we often learn from patients and families, but that we try to help people with. Absolutely.
Thank you so much, Dr. Vaughn, for your time today and for giving this wonderful presentation. I am sure that our families are going to be using this and referring back to this for a lot of time to come. That's all the time we have today. We hope you found this presentation to be informative. We will post the recorded webinar on AFTD's website under News and Events and send out the link as soon as it is available. The next AFTD Educational Webinar will focus on the role of creative arts therapy and engagement in FTD care. Caitlin Hebb of Med Rhythms, Inc., art therapist Deb Del Signor, and Melissa Uva of Clear Guidance will lead the webinar on October 28th. Stay tuned to AFTD's website and social media channels for registration information as it becomes available. Thank you for joining us today. Please let us know if you have any comments or questions about today's presentation, or about how other ways AFTD can assist you moving forward. And be sure to visit our website and make use of the AFTD helpline if you need to. Until next time, have a good day.